So the purpose of this video is really to go over the stimulus questions to just save us time during our presentation. It's something that we asked Ashley about. She said it's probably a good idea to save time. We could kind of do more explaining on some of the stuff that our patient has going on. He's a 12-year-old athlete who broke his collarbone playing football. It's really good to see a video on how good he is tomorrow, but we're going to go over just the 4 stimulus questions here in this video. It'll be real quick. And it's important to pay attention because we're going to make a really hard quiz that you have to pay attention, or that you have to focus on, because we're going to try to trick everybody and you'll probably fail. So pay attention to the video because it's going to be really good. So our first stimulus question is pretty much explaining primary and secondary intention of bone healing and which one's going to be occurring with our patient, and then we'll relate that to some healing timelines. First thing to do is look at the bone repair that is occurring in this patient, which is secondary intention. And these bone pieces, they have shifted more than a millimeter apart from each other. And as we all know, this is the most common form of bone healing, being secondary, because the fracture has caused a gap that eliminates the stable conditions at the fracture site. Secondary healing will involve an inflammatory phase, a soft callus formation, hard callus formation, and then a remodeling phase. The primary bone healing, which is not going on here, is going to occur when there's less than a millimeter of shift in bone pieces. And this type of healing is also going to occur when is usually going to require surgery to fix the problem with internal hardware or something, but it can naturally heal on its own, but is really rare. Healing is initiated in that phase by osteoclast and then accompanied by osteoblast and capillaries. Lamellar bone is formed, primarily oriented in the right direction to help with healing. And then there's going to be no formation of a periosteal callus during primary healing. With this patient, though, we're in secondary healing. We're going to have 3 stages of healing, which is going to be inflammatory phase, reparative phase, and remodeling phase. In the inflammatory phase, we're going to have a hematoma formation and cellular proliferation. The inflammatory phase is characterized by hematoma formation, and severity of the hematoma is going to depend on the number of blood vessels that were damaged by the injury. Reparative phase is going to be a callus formation that brings the broken pieces together, and ossification of that callus begins, and osteogenic cells proliferate from the periosteum, then the endosteum, and form a callus. There will be no bone in the callus in this stage, at least very little towards the end, because it's still the reparative phase, and then the cell, or that callus, is still going to be kind of cartilaginous. And then the osteogenic cells eventually will differentiate in osteoblasts and chondroblasts and form bone and cartilage, respectively. Remodeling phase is going to be pretty much consolidation and remodeling of the bone and callus that was formed in the reparative phase. The remodeling is going to consist of 2 parts, a clinical union and a radiological union. During the clinical union, we're going to have a fracture site that is firm and there's not really any movement at the site, and this is going to occur when the callus consists primarily of woven bone and just a little bit of cartilage left over from the reparative phase. This is going to harden, and eventually, as the cartilage ossifies, it will immobilize and no longer let the bones move, and then the movement of the related joint is also going to be allowed with caution. So in this case, the clavicle is healed. We're going to be able to allow it to move the scapula. During assessment of this site, there should be no movement of the site looked at by the PT, and the patient should feel no pain when tested. Then in the radiological union, they're going to be bone healed or consolidated, or the bone is going to be consolidated, and it's going to occur when temporary callus has been replaced with mature lamellar bone. And the callus is going to be resorbed, and the bone is back to normal, so we don't see any more remnants of a bump or can't feel any kind of callus there. As far as healing time, it's going to really vary based on the location of the injury, the age of the patient, whether or not the fracture was displaced, the blood supply to the area, that kind of stuff. But with this patient, he's a child, he's 12 years old. Children usually heal, they're usually healed between 4 to 6 weeks, where adolescents are closer to 6 to 8 weeks. And with him being 12, he's probably right in the middle, so we're going to err to the side of 6 weeks and just let that be what we're going to go with. And then that's really going to start our chronic stage of treatment, which we'll go over during our presentation. And you'll see we're going to move to a lot more functional activities for that time. For this patient specifically, we're going to see that the initial eval was done during the reparative phase, about 10 days out from injury. And the patient is still going to be immobilized, wearing a sling. He's going to have pain, in this case 2 out of 10 in his shoulder, or at the fracture site. Subacute stage is going to be during the remodeling phase, which is more specifically the stage of clinical union. And we'll know this because we can still see a bony callus, and there's there's not going to be a need for a sling or any kind of immobilization during this part. And finally, in that chronic stage I was telling you about, after 6 weeks, we're going to be in that radiological union. We know this because there's no evidence of a bony callus. Second question we'll go over is how delayed or impaired bone healing is going to affect upper extremity function. And delayed or impaired bone healing can lead to a malunion, a non-union, or delayed union. And malunion is going to be when the bone heals, but it's not to a desired function. So it can result in the bone being shorter than normal. It can heal into a twisted position, which isn't ideal, or it can heal into a bent position. All of these can affect upper extremity function by potentially changing the osteokinematics in relation to other structures like the scapula or the sternum, so it's going to affect how we move in those different planes. This could also potentially put the scapula in positions that are not ideal to perform the ADLs or those specific to football. Impaired healing is going to be is also lead to non-union, so impaired healing can also lead to what's called a non-union, which is pretty self-explanatory, I think, and it's where the fracture fails to heal and rejoin two separated pieces of bone, so in the clavicle, just whatever, reconnect. This can definitely, obviously, cause upper extremity problems when it comes to function because the fracture does not allow connection between like the scapula and the sternum. So the scapula moves, the sternum won't. The sternum moves, the scapula won't, for the most part. So again, the osteokinematics and arthrokinematics even potentially are going to be altered, potentially even unable to occur, depending on how severe that non-union is, especially if it's completely split down the middle. As far as a delayed union, this is going to the stages of healing that we talked about earlier are just going to be delayed. So if we're stuck in an inflammatory phase and that's going to be delayed, then obviously we can't treat the same way at day 10 as we would with it being a normal healing process. We can't put heat on it. We're not going to be able to move a lot because the goal of inflammatory phase is to rest and let that heal and not aggravate any kind of inflammation that could, make that worse. And so it can lead to just prolonging of those phases, and which would slow the treatment process, slow the progression. If it's prolonged too much, then the callus is going to take longer to form, which is going to push back the other stages as well, meaning subacute and chronic, and then we'll not meet our goals in the time that we've set, and then we won't be able to do the exercises that would improve function and return him back to the football field like he wants to do, so he can't achieve those goals. As far as the next question is going to be explaining differences of bone healing in children versus adults. As we've been over before, there are a lot of differences between bone healing for children and adults, but it's going to affect how they respond to therapy and treatment and how quickly they heal. Children's fractures heal more quickly and for a variety of reasons, one being the nature of having a thick periosteum. This periosteum is going to help stabilize the fractures, and then because of this, the child's going to respond well to immobilization and regain their normal range of motion quicker. Pediatric bones are more porous than adult bones, which is going to result in a different fracture pattern than adult bone, which is going to help it heal quicker. Pediatric bones are also more elastic and bend easier, meaning it requires a greater energy to break them or cause them to fracture, displace them, whatever. And then, as you've probably studied before, green stick fractures and torus fractures, meaning as you bend, the top's going to shatter and from the stress, and then torus fracture is going to be a twisting of the bone. Those are the two most common fractures in children. Children's bones can be prone to breaking due to the presence of that epiphyseal plate, as we talked about before. Just lower density there and less bone, more cartilage. It's just a site of weakness. 15 to 30% of the pediatric fractures occur at the growth plate, and of those, probably 1 to 10 of those growth plate injuries result in some kind of growth disturbance. So it's really important to make sure we're addressing those when looking at people that are prone to epiphyseal fractures, being children. The avulsions fractures, which is pulling bone off of the bone, are not uncommon because the bones are less dense, and the fracture can occur because the ligaments and tendons are stronger than the bone itself, and then as the muscle contracts, it can pull the ligaments and tendons really hard, and if it's too great of a contraction, then we're going to be able to pull the bone off, separate the bone just by pulling it apart. And the last question we'll go over is just describing considerations and modifications of plan of care when treating a prepubescent child versus treating an adult. So our patient's name is Sean, not Sean Horan. He's obviously not a prepubescent child. He's married and a grown man. But our patient Sean is in this peak rate of growth, or at least approaching it, depending on where he is in puberty at the age of 12. And then he's going to continue this peak rate of growth until he's about 18 years old. As of right now, his epiphyseal plates are still open, and his bones are in the process of ossifying. So therefore, it's extremely important to remember that any hindrance to his growth at this point could be extremely detrimental. We don't want him, especially a stud of an athlete he is, we're not trying to make one leg longer than the other by injuring him further, or one arm longer than the other in his case, I guess. It's also important to remember that ligaments and tendons, again, are actually stronger than the bone. So with too much stress, the avulsion fracture can occur. According to our WCK book, some basic resistance exercise guidelines for ages 11 to 13, which are perfect for Sean because he's 12, are that we're going to teach them all the basic exercise techniques. So make sure they really understand the proper way to do things. And then we're going to continue progressive loading for each of those exercises while really emphasizing the exercise technique, making sure that they have understood it from what we taught to them, but then how we're going to really emphasize that they practice it. Then we're going to introduce advanced exercises or more functional stuff with little to no resistance, meaning we're going to pretty much stick with body weight stuff, which we all know from being harped on over and over. And then we'll progress into more advanced youth programs in resistance exercises. So for Sean, we may even go into like some kind of Throwers 12 program with some really tough bands, or like a velocity program with the weighted balls, or even like a sport-specific football throwing program to further his functional goals, or his goals of achieving functional motion that are football specific. And then we're going to add some sport specific components. So maybe we'll go from the throwing to making him roll out and throw on the run, or making him do sprints, or something that's obviously specific to football. And then finally, we'll increase the volume when that stuff gets too easy. Just to be on the safe side, we're always going to have the interest of the patient in mind. And then it's going to be best for us to mainly use body weight with Sean, unless it's just super easy, and then we can slowly introduce some resistance depending on the exercise, obviously. Another thing to consider is that we create a treatment plan that maintains the patient's attention. So as a child, it's really easy to get distracted, obviously. So if we make a boring exercise plan where he's laying on a mat all day and doing stretches and band work, he's going to get really bored and not get anything out of it. So we're going to make sure we're doing quote-unquote fun exercises that are more functional, and then just a variety of different exercises so that we can keep his attention and keep him fully involved in the treatment so he's not quitting on us. So that's all of our stimulus questions. I hope you come prepared, because we're going to, again, make a really hard quiz and try to trick you, and I hope you fail tremendously. I'm just kidding. You're going to pass, because we'll probably give you the answers either in this video or in the presentation. So just take it.